Welcome, everybody, to another special Tuesday edition of VMR. It's a POCUS edition VMR today, and I'm very happy to have all of our POCUS friends and experts here in attendance. I see Dr. Sanjay Patel will be presenting a case, and he's hailing from all the way from Riverside, Ohio, one of the programs that was featured on one of our global VMRs recently, a great case of poems that I had to tackle. And then I also have Dr. Daniel Restrepo. I see Dr. Ria Dansel. I see Dr. Gigi Liu and Dr. Travis Smith. All of our POCUS friends, CPS friends are here in attendance. And Dr. Daniel Restrepo has kindly accepted to co-discuss the case with me today. So I'm going to ask Dr. Sanjay Patel to unmute for a bit and just tell us a little bit about himself.
Sure. Thanks, Ravi and team for having me on again. It's always a pleasure. For those I haven't met or interacted with, I'm Dr. Sanjay Patel. I'm Associate Program Director for Internal Medicine at Riverside Methodist Hospital at Ohio Health in Columbus, Ohio.
And I'm going to ask Dr. Daniel Restrepo also to unmute and introduce himself.
Hey everyone, my name is Dan Restrepo. I'm one of the members of the core teaching faculty and also the Associate Program Director for Point of Care Ultrasound at MGH in Boston.
And Dr. Restrepo is also a great friend of CPS, tackling some of the Monday clinical reasoning series, expert series. So it's always great to have you here on a Tuesday afternoon. So shall we start with the first aliquot and deploy the board?
Sounds good. Let me know when you ready.
Yeah, I think we can start while they get the whiteboard up.
Okay. Just so we have some time to go over the images, I'm going to give you the HPI, or at least a decent part of the HPI first. Have a 67-year-old man who presents with about 1 month of shortness of breath. He initially had some sinus congestion, a runny nose. These URI symptoms kind of waxed and waned, but slowly improved over the course of time. However, now he feels out of breath walking up the stairs, has to stop to catch his breath when walking more than one city block. He has a mild cough with clear sputum production, does have some right upper quadrant and right lower quadrant abdominal pain. This precedes the onset of respiratory symptoms. He describes this as constant, achy, no obvious alleviating or exacerbating factors. It's been going on for about 4 or 5 months on and off. He does have a 20-pound weight loss over the past 3 to 4 months, mild orthopnea, no bendopnea, no PND, chest pain, nausea, vomiting, no palpitations, night sweats, diarrhea, bleeding. I'll stop there.
All right. So we have a 67-year-old man who's presenting with sounds like subacute exertional dyspnea. Dr. Patel gives us a little bit of a preamble, which could suggest a viral prodrome, which in general makes me think about a couple things. Is this sort of like a virally triggered syndrome, meaning like, did we trigger sort of cardiac disease after a viral infection? Post-viral myocarditis, is it sort of like the prime example of that? Or is this sort of, was a viral infection the loading condition for a second infection? So often you want to really think about post-viral pneumonias. Usually the story that you will get is what's called resickening, a second hit, kind of I was getting better when boom, and then I kind of fell off the wagon again. Doesn't have a lot of historical findings that would suggest decompensated heart failure or a recurrent sort of secondary infection. So then our third bucket leaves us with whether or not the viral syndrome, quote unquote. You'll often hear viruses blamed for a lot of things that actually weren't viral in the first place. So whether or not the viral syndrome entirely was fake news from the get-go, and that would maybe tie in with the longer, more insidious weight loss that he had. Maybe sinopulmonary syndromes could include things like ANCA disease. You could consider malignancy with all of the weight loss, especially something that's up in the right upper quadrant. So certainly we'll want to get a a good exam, notable medical history. And yeah, I'll turn it over to Dr. Singh for any additional thoughts.
Also, those are exactly the same thoughts I had. Sort of system one thinking immediately right off the bat was, no, this can't be a case of a viral prodrome causing some sort of cardiac disease, but there may be something more ominous going on. The weight loss is a harbinger of some serious disorder. Could it be inflammation, or like Dr. Restrepo mentioned, could there be malignancy here? I'm just going to sort of tune into, or just take what Dr. Restrepo mentioned, plus add to that abdominal pain. So I think it's sort of not something that is going to allude to what is the cause of this phenomena that's occurring here. But this abdominal pain, I would kind of like to explain it that it could be maybe secondary to something that's going on in the thoracic abdominal area, or could it be, when you have a patient coughing frequently, you do tend to have abdominal pain because you use those abdominal muscles to exert that cough. So it could be, if on exam you do something, I'm forgetting the sign, but there's a sign that you do, Carnot sign, to determine this abdominal pain involves the abdominal musculature, or is it something deeper? So look that up. Carnot sign it's sort of like when you have chest pain, is it superficial chest pain due to the intercostal muscles, the costochondral junction, or is it something deeper that could be the cause of the chest pain? So here right now, I'm not quite sure where to really invest all my cognitive effort, but I'm still stuck on that system one thinking that Dr. Restrepo mentioned. Is this something, a prodromal viral phenomena that leads to cardiac involvement? But as we get more information and then the POCUS images, I definitely would like to take a look at the heart. Back to you, Sanjay.
Sure. Yeah, great thoughts so far. So past medical history of high blood pressure. Social history is a 40-pack-year tobacco smoker, quit approximately 4 years ago, never used illicit drugs, drinks alcohol about 1 to 2 beers about 2 to 3 times per week. He is a retired construction worker / handyman, is married with 4 adult children, originally from Poland, has been living in the United States for about 20 years. Family history, only thing that he is aware of is coronary artery disease in his father, and medications, amlodipine sporadically. He does not see a primary care provider regularly, so this is filled as needed, essentially. So I'll give you the physical exam as well. So the blood pressure is 117/65. Heart rate is 112. Tmax is 97.5 Fahrenheit. Saturation is 96% on room air. Respiratory rate is 22. His BMI is 20. On general exam, he's not in any visible distress. He does appear thin and cachectic. Head and neck exam is normal. Heart, irregularly irregular. He's tachycardic, has normal S1, S2. Lungs, there's decreased breath sounds on the right middle and right lower base. Otherwise, they are normal and non-labored breathing. Abdomen has mild right upper quadrant and right lower quadrant tenderness to deep palpation. There's no shifting dullness, but the left side of the abdomen is tympanic and the right side is dull to percussion. There's trace pitting edema, no clubbing, no rashes. Is alert oriented ×3 on neuro exam and otherwise unremarkable. And sorry for the head and neck exam. There is no visible jugular venous distension.
All right. So I think the exam at least may not be a slam dunk for anything, but it'll give us certain hypotheses to chase down. So we have tachycardia and tachypnea. With, I believe, an irregular pulse. Is that correct, Dr. Patel?
Correct.
Okay, so regardless of what we find, this guy is sick. And some of you may be reassured by a normal, by the absence of hypoxemia. I would counsel you to not be. So tachypnea is never a good sign in people who are hospitalized. And there's a plenty long list of sinister things that causes tachypnea without hypoxemia. So in the presence of tachycardia and tachypnea, I am now concerned about this man. the presence of cachexia and this sort of like wasted sort of description that Dr. Patel gives us is suggestive that this is going to be more of a chronic syndrome with perhaps a superimposed hit or a progressive kind of tempo to it. With the sort of the dyspnea and the tachycardia, with the some of the pulmonary findings, I do have to kick around that. Could this be a pulmonary embolism in the setting of perhaps an undiagnosed malignancy thus far? I do think that sonographically we could learn a lot about what's going on with this guy with both lung and limited belly ultrasound, as well as focused cardiac ultrasound. So as I'm thinking about what I'm going to grab the probe and look for, that's going to be some of the stuff that where my eyes are going to be drawn. We can with POCUS we can see probably better than a chest x-ray, we can see signs of consolidation. I would note that a pulmonary infarction looks exactly the same as a consolidation on ultrasound. And since it can also be hard to tease apart on CT, but it'd be great to do an assessment of his lungs with ultrasound to tease apart that diminished breath sound that we hear over there. Is that a pleural effusion, which could also be in the setting of malignancy? Is this, like I said, bacterial pneumonia? Is this pulmonary infarction from pulmonary emboli? And also just to get a sense of his volume status by looking at his the rest of his lungs would be pretty useful, and it perhaps would give us a little bit of information about what's going on in the belly. But I suspect we'll get labs before that. But those are the things as I'm trying to kind of unify the belly with the chest. That's where my brain went. Turn it over to you, Dr. Singh.
Absolutely awesome. My brain is following you, hanging onto your coattails. I love that. Yes, this patient is sick. Patient has definitely lost weight, and the patient is having what we sometimes call a fever of the heart. So the tachycardia, the patient is registering that they're having quite a bit of effort trying to compensate for who knows what. I'm not quite sure. Maybe some of the things that Dr. Restrepo mentioned. But this examination of the right upper quadrant, for some reason, I was thinking both right upper and left upper quadrant, there was pain, but right upper quadrant, there's pain. Then the exam is phenomenal in that it allows us to then decrease the work of focusing our examination. So now our examination will have to focus on the right upper quadrant, and a couple of things that Dr. Restrepo mentioned, and then Dr. Dansel mentioned in the chat, like shortness of breath without hypoxemia, maybe pleural effusion, but ominous conditions like pneumothorax or a pulmonary embolism, these sort of things would actually cause hypoxemia. So pleural effusion, anemia, also something I'm looking for. But the anemia, if it is present in the patient, could it be secondary to a bleed? Could there be a hematoma collecting in that right upper quadrant area? Then a couple of people alluded to in the chat, what are the organ systems that locate in that right upper quadrant region? So maybe a liver associated issue. So hepatomegaly, I was thinking, interestingly, I like with cirrhosis, you get platypnea, orthodexia, these kind of funky oxygen associated disorders. But with this patient, we're not registering that with positional, no change in the shortness of breath with position, no orthopnea, no platypnea or shortness of breath when sitting forwards or orthodexia in this patient. So hepatomegaly would not coincide or correlate with hepatomegaly. But then again, we have to consider this with percussion, which can be a very, very interesting exam. Sometimes we forego, but just doing that will help us consider maybe there's some process that's going on in the right upper quadrant. But yeah, I'll kind of leave it at that and see what the labs indicate to us. Back to you, Dr. Patel.
Sure. So I'll give you some basic set of labs that were done in the emergency room. So for the BMP, the creatinine is 0.7, calcium is 8.9. The rest of the BMP is essentially normal. Total protein is 5.7, albumin is 3, AST, ALT, and bilirubin are normal. WBC is 16,000, neutrophil predominant. Hemoglobin is 12 with an MCV of 79. and platelets are 598,000. PT and INR normal. EKG shows atrial fibrillation, and chest X-ray is read as suggestive of a moderate to large right pleural effusion.
Okay. So the CBC tells us that there is inflammation, and the presence of a thrombocytosis would actually usually suggest chronicity to it. Thrombopoietin is an acute phase reactant. However, in my clinical experience, thrombocytosis isn't seen until more sort of subacute to chronic inflammation is present. So, so the CBC shows us he's inflamed. He's not strikingly anemic. His MCV is teetering on the edge of low, which can be seen in anemia of chronic inflammation, but also should make us think of superimposed iron deficiency as we're mulling around the worry of an underlying malignancy. The chemistries are notable in what they are, in that they are very, very normal, except for perhaps some signs of chronic inflammation with his hypoalbuminemia. His electrocardiogram confirms our exam. And in this case, this AFib, given how sick he is, I would worry that this is sort of provoked AFib as opposed to primary AFib. And again, I just don't trust chest x-rays. The more lung ultrasound I do, the less I trust chest x-rays. I've seen a lot of big consolidations get called effusions. Again, in pulmonary infarction would tie in the AFib with the dyspnea that he's having, and possibly through a PE, especially in the setting of underlying malignancy. And lastly, just because he has an absence of fever when we're seeing him now currently, post-viral empyema from a more indolent organism, you may see this, especially as people get older. It does cause a wasting syndrome rather than like a true classic pneumonic syndrome. Like, it's not that I'm coming in spicy with fever and productive sort of cough, but rather it can be insidious. I'm losing weight, I'm sweating through my sheets. The pain that he's having in the right upper quadrant may very well be referred from the pleura. So lung ultrasound here would also help us sort of assess for complexity within the pleural cavity if it truly is an effusion. And you know, that does kind of more sort of anaerobic organisms, mouth bugs, things like that, can give you more subacute presentations with empyema.
Yeah, it's interesting that the EKG was there, but I didn't really focus. We didn't really focus in on the irregular heart rhythm. So just treading a few steps back, if I really had started going through the causes of irregular heart rhythm, regular rhythms would be number one, AFib, which probably is the most common arrhythmia that we see, or you could have MAT or a normal rhythm with aberrant conduction. So any regular rhythm with aberrant conduction could manifest with an irregular rhythm. So here, patient has the most common irregular arrhythmia, which would be atrial fibrillation. Now, why would the patient, this is new onset, I believe, Dr. Patel, right? No history of atrial fibrillation?
Correct, to the best of our knowledge. However, I will say he's probably only seen a physician about 3 or 4 times in the last 10 years.
Yeah. So we assume it's probably his first index event of atrial fibrillation. I usually break down AFib by a number one, cardiac causes. So you can have valvulopathies. Does he have a structural heart disease, which we alluded to in the first aliquot? Decompensated heart failure, or is this new ischemia, which I doubt is occurring this very moment? Non-cardiac causes, obviously pulmonary disease, so any sort of pulmonary disorder, COPD, pulmonary embolism, then endocrinopathies, namely hyperthyroidism and metabolic disorders could promote an episode of new onset AFib. And then infection. So here, as Dr. Restrepo mentioned, with the white count being elevated, and there was some signal of infectious disease with this patient with some weight loss, this URTI. So could this have manifested into this systemic process? So again, I'm not sure where the infection could be. Maybe this exam finding in the lung, like Dr. Restrepo mentioned. A white count of 16,000 is pretty significant. And like with the platelet count, another cause, I think Dr. Restrepo is iron, with what you mentioned about iron deficiency anemia, the erythropoietin can mimic thrombopoietin, thus causing an elevation also in the platelets. So 2 reasons. inflammation and iron deficiency anemia. But at this point, I think with the X-ray, I think we need to go further, maybe a CT or maybe deployment of an echo probe into that area. So back to you, Dr. Patel.
Sure. So I will go to our POCUS images here to supplement our physical exam and diagnostic information that we have so far. And I can second what Dr. Restrepo said. It's hard to trust the X-ray, so that's why we have ultrasound. Let me make sure these images are. Can I share my screen? It says sharing is disabled. There we go.
I think we just made you co-host.
All right. Are you able to see my screen? Yeah. Okay. So we did a fairly extensive imaging with point of care ultrasound. I won't show all of the images, but just with some basic cardiac images, essential interpretation was LV ejection fraction was normal. There was no pericardial effusion. The RV looked okay. There was some LA dilation, and the IVC in longitudinal view appeared to be normal in diameter with normal respiratory variation. The upper portions of the lungs, there was normal lung sliding and A lines in both upper and middle lung zones. So this is the image of the left lung base. I'll let that play for a few seconds here.
All right. So we have a left lung base image, and Dr. Patel, just to confirm, the quote effusion on the radiograph was on the right. Is that where the same sort of right upper quadrant pain is noted?
Correct.
Okay. So we have here, this is sort of the left lung base. What I'll call your eyes as you're interpreting these images is that there's sort of a curvilinear hyperechoic line in the middle of the clip. That is the diaphragm. Below the diaphragm, thus it should be noted that there's an isoechoic structure in the near field. That is the spleen. Since I know we're on the left, that's the only reason I know it's the spleen. Beneath, in the deep field to that, there is a kidney that's present there. You'll see right there behind, in the furthest field, the deepest part of the image, you'll see sort of these kind of sort of ridged or ruffled hyperechoic areas down behind this. That's the spine. That lets you know that it is the most dependent zone of both the thorax and the belly. And if there was something that allowed an image or allowed sound to transmit through the lung above the diaphragm, like a pleural effusion, you'd see a continuation of those bright white ridges north of the diaphragm, which we're not seeing here. However, we are seeing something that's generating sound at the left base in the lung, which is tempting to call a consolidation. However, a consolidation should have that spine right behind it, since it can technically carry the sound through the chest to the spine. So this is actually mirror image artifact more likely than not, which is just the finding that says it's sort of an ultrasound artifact that basically says that this is nice air-filled lung that is at the left base, as opposed to a consolidation. So it's a bit of I think Dr. Patel is trying to trick me here.
No, I'm not trying to trick you. It's certainly agreed with you. This was after looking at all of the images, and after the fact, kind of saying that this is in fact mirror artifact. There wasn't anything on the left side of the lung, but we did do it for comparison.
So if there is mirror image artifact on the left side of the lung, or on this left basilar lung zone, it means that the left lower lung is pretty pristine. So is absent or devoid of any airspace disease or a pleural effusion here.
All right, so I'll give you, sorry. Now this is the right lung base.
And so turns out that we can probably trust the X-ray here, but notice that you'll have that same kind of line that divides the clip Below that is actually what the liver should look like. And above that is sort of a multi-loculated complex fluid collection with a bunch of things that look like spider webs in them. So those are actually probably strands of fibrin from a complicated effusion at this point in time. And just to kind of close the loop, and the clip is not in the exact perfect way to illustrate this point, but there is a hyperechoic line in the deep field there, in the far field of the image, which is actually the spine. So now there's loculated fluid that's in the chest that's allowing the sound from the probe to reach that bright, dense spine. And so that's probably part of why you're seeing that hyperechoic line in the back. Now, calling our eyes to all this kind of like mess of spiderweb stuff, this is very indicative of a complex effusion, which almost all of which are exudative in nature. I think this largely raises the differential diagnosis for one of two things: empyema or malignancy. So they can both really look like this. In theory, kind of other stuff like TB, but his epi is not necessarily correct for that. So my money is on either a post-viral empyema in this case, with that kind of preamble of upper airway symptoms, or malignancy, given all the weight that he's been losing. And at this point, this is a solid indication for at least thoracentesis, but more than likely actually tube thoracostomy of the chest. And I would love to get gram stain culture, glucose, LDH, cytology, cell counts, and go from there.
And then I'll give you one final image. The left side of the abdomen, just for purposes of time, was essentially normal. And this is the right upper quadrant. I can see Dan's face there.
Oh, wow. So as far as and I see people who are much more expert than I am at point of care ultrasound on this, so I may end up phoning a friend, but in general with POCUS, at least my lowly internist, with my lowly internist hat, my question when I'm ultrasounding the belly is whether or not there's the presence of free fluid. So there are anechoic locules of fluid that are surrounded by more of these hyperechoic sort of strands, which would suggest that there is fluid in the belly, but that it is not necessarily in a free nature, but it looks like kind of complex loculated fluid collections in the belly, which are really interesting. But I would agree with Dr. Denzel in terms of her commentary here, but there is complex fluid in the chest as well as in the belly, which is a very interesting clinical conundrum here. I think we need to sample this fluid to figure out what's actually causing it. And at this point in time, I also do think, as much as this is a POCUS conference, this is an indication for contrasted cross-sectional imaging with a CT of basically the torso, chest, abdomen, and pelvis. But I'd love to hear Dr. Liu or Dr. Denzel or any of the other POCUS experts that are on here, in case I'm missing anything. There appears to be something under the diaphragm there, right above the liver as well.
Yeah, and I don't know if Ria or Gigi want to comment in, but I agree with you, Dan. Essentially here, where I'm pointing in the middle here is the liver, and around the liver, from the capsule up to the abdominal wall and out, you can see all these loculations of fluid here. So a complicated acidic fluid, which would explain the symptoms that he was having in the abdomen, and then a complex right pleural effusion.
And this guy didn't have diabetes or that we knew of at the time.
None that we knew of.
No liver disease, and you said not heavy on the alcohol use. No prior operations in the belly.
Nope.
So the question is, I mean, if you were to think about probability, it's probably the same process on both sides of the diaphragm. So was it a chest that moved into the belly? Or often, sometimes, liver abscesses or abdominal pathology can actually track up into the pleural space without the abdomen, from going belly to chest. This is a crazy case.
So, Dr. Patel, this is Gigi. Presumably the diaphragm direction is toward the indicator, right? Like diaphragm would be further up that way.
Correct. This isn't a perfect image, but it was the most representative one that I could find that I had enough time to save.
Just curious, I know we didn't ask about some of the history. Patient has history of ascites or liver issue or had recent paracentesis TAP before? Because then the other possibility may be too much TAP, infection in the belly, spreading up to the lung, especially if there's like a hydrothorax kind of etiology potentially going on.
Yeah. As far as medical issues, none that he is aware of. Very sporadically has seen any healthcare provider and never had any intra-abdominal procedures done before.
Just one question.
Okay, this is, sorry.
Oh, go ahead, that's fine.
It's Ria. This is really fascinating. So we talked about, is this going from the liver or the lung or the chest cavity into the abdominal cavity, or the abdominal cavity into the lung cavity? And I wrote in the chat that generally the direction, if you think of the diaphragm as being a one-way valve, generally infections will spread from the abdomen into the chest. And if you think about it, the chest has negative intrathoracic pressure. So every time you take a breath, if there are defects in the diaphragm, as there are in a lot of people, fluid moves from the belly upwards. So I am so interested to see what this fluid sample looks like.
And I can.
I was going to ask also, I don't see any parenchymal involvement. The liver looks pretty pristine. Would you agree that? Or is it too difficult to say that on a POCUS image?
Personally, I would say it's a little difficult to tell, at least from this view. I don't have really any better views, but a lot of it is that the liver is kind of shrunken and tethered to the abdominal wall, so it's a little difficult to tell. All right, so I will stop sharing the images here, and this is how the patient came to me. And being a proceduralist, I was super excited to tap both the chest and the abdomen. So I will give you fluid studies from the pleural fluid first, and then I'll give you fluid studies from the ascites. So from the pleural fluid, gram stain and culture was normal. The color was reddish and brown, reddish brown. WBC count was 248, of which 21% was neutrophils. Red blood cell count was 126,000. Protein was 4.1. LDH was 734. Glucose was 101. pH was 7.5. And amylase was 8,000. And then with the acidic fluid, gram stain and culture was normal, also reddish brown in color. WBC was 176, 18% neutrophils. Red blood cell count was 173,000. Protein was 3.8. Albumin was 2.7. Amylase was 11,000.
So the findings of amylase in a pleural effusion means one of two things: either esophageal rupture or pancreatic ascites most of the time, or a pancreatic pleural effusion. The fluids themselves seem to be pretty similar and characteristic both above and below the diaphragm, which kind of confirms the same suspicion that we had earlier. With the very high acidic amylase would suggest that this is perhaps all pancreatic ascites, though I would want cytology on this fluid. Dr. Patel, did I miss cytology on either of these fluids?
Apologies, I did not give that. So cytology on both fluids was negative. Okay.
Which does not entirely take malignancy off the table. Just to be really explicit, a lot of visceral malignancies can have ascites with negative cytology. So I do still think that this guy merits a CT of the torso. And then based on his, let's just say, sporadic contact with the healthcare system, I'm assuming he's not had age-appropriate cancer screening, Dr. Patel.
No.
But this does raise the possibility of like just complicated pancreatitis that he never really sought care for, that is all here, or a pancreatic malignancy as a potential explaining cause for a lot of what we're seeing. And I did see in the chat, and we had mentioned earlier, that technically tuberculosis can cause all of this. His epi for it doesn't necessarily map on as well, or his immune competent state.
Yeah.
There was also a history of alcohol use in the past.
He did not, right?
He didn't?
2 to 3
4
years
years
a
ago.
week. But yeah.
Okay.
So yeah, I can give you some more information. The I see somebody, or Dr. Dancel said in the chat to send a whole liter for cytology. Everything that we had was sent for cytology, and it was negative. Just some extra information with both fluids, since Dr. Restrepo brought up the possibility, albeit unlikely, of tuberculosis. ADA was sent on both fluids and was unremarkable. And in the cell counts, there was presence of mesothelial cells in both the pleural and the acidic fluid. And so imaging was done, chest, abdomen, pelvis. Chest imaging, right pleural effusion. However, the rest of the chest was unremarkable. There was this right upper quadrant ascites / amorphous fluid collection that appeared to track over to the pancreas, but was difficult to tell if it was separate from the pancreas or surrounding the pancreas. There was some mild peripancreatic fluid and probably fat stranding, and it was read as possibly an amorphous pseudocyst, but clinical correlation advised as usual. And just some extra testing that was done. Lipase was 297. A HIV test was done, which was negative, and an autoimmune panel was done at some point in here, and ANA was positive of 1 to 160. However, ANCO was negative.
Wow. And nothing, no malignancy on the cross-sectional imaging, and nothing on the fluid. So you have mild persistent lipase elevations. And there was any stranding, any stones, any ductal dilation in the pancreas, anything like that?
There was no, sorry, repeat your question again.
Was there pancreatic edema, stranding, ductal dilation, atrophy in the pancreas, anything in the actual parenchyma of the pancreas?
Peripancreatic fluid and fat stranding. There were no stones that were obviously seen. There were no calcifications that was seen. There was a comment of possibly mild ductal dilation, but it was nonspecific.
So overall, not a bad constellation of imaging findings to suggest sort of ongoing or resolving pancreatitis, perhaps with acute on chronic pancreatitis, and just really bad luck.
So yeah, I mean, that was the initial thought based on the conglomeration of findings. We did ask our consultants to come see him. They did do an ERCP. They did note an occlusion of the main pancreatic duct, for which they put in a stent. They took some brushings, which also turned out to be negative. And so the initial working diagnosis was some form of acute on chronic pancreatitis that has probably been going on for some time. However, the patient came back a couple times successively over the course of the next couple months with recurrence of the effusions. The main pancreatic duct was evaluated again. There still seemed to be some sort of occlusion, even despite putting the stent in. So a repeat imaging was done, and on the second repeat image, there seemed to be more consistent findings of a interpancreatic mass. And ultimately, that was when that was finally biopsied, it was consistent with pancreatic adenocarcinoma.
So a great learning point is that usually it's neuroendocrine tumors which can hide, but sometimes adenos can hide. And the diagnostic test of choice there is actually an endoscopic ultrasound, which may show actually a smaller amount of other things. The only other thing that you need to think about in folks that keep restricturing or that have this disease would be autoimmune pancreatitis secondary to IgG4 related disease. He's a bit young for it, but that's the other thing that usually comes into the differential diagnosis. But adenos can hide. Usually neuroendocrine tumors hide better than adenos, but adenos can hide. And so if you ever have a person that has acute pancreatitis or acute on chronic pancreatitis for reasons that are not suggestive of it, that you don't have a clear sort of alcohol, gallstones, drugs kind of history, you got to think about, especially in somebody this age, start thinking about pancreatic adeno.
Yeah, I just wanted, there was a comment in the chat that Dr. Liu had put in. We did end up repeating the thora and the para at some point later down the line. Repeat cytology was sent, as Dr. Restrepo mentioned, not a negative cytology on the first testing, not necessarily an extremely sensitive test. However, each successive procedure continued to be negative for malignant cells.
Very interesting case. I was his picture was very murky, trying to figure out with what's going on with all this data. But I think with the abundance of white cells and red cells, that does indicate with the history, weight loss, and recurrent abdominal pain, that this was possibly malignancy. We're between malignancy and infection, but a lot of your data didn't point out anything infectious going on. But I think the important thing was to keep at it to figure out. What's interesting, all the repeated interventions, you weren't able to find any debris of this malignancy because it was just located, like Dr. Restrepo mentioned, it was just hiding not in plain sight actually. But the important thing was to keep going at it and doing additional interventions to finally find the answers. So incredible case. It's I've never seen even pancreatitis manifest like this, or even adenocarcinoma manifest with such pictures. Thanks for bringing this case. Really appreciate it. Any final thoughts? Oh,
absolutely.
Sorry, go ahead.
Absolutely. Just and I wanted to bring it partly from the procedure standpoint, but also from ultrasound. You know, we see complex pleural effusions or complex ascites, and I think our initial inclination is always cancer and infections. But any sort of chronic inflammatory process can also cause those. So to be vigilant about expanding your diagnostic testing when your initial first pass of things don't end up kind of panning out to what you think it might be.
Any final reflections, Dr. Restrepo?
It was a roller coaster. You took me on a roller coaster ride, Sanjay.
That's the goal.
And so I think one reflection, as everybody, like, there is a cognitive bias that's known as search satisfying. And search satisfying is basically a fancy way of saying I turn my brain off when the first possible explanation pops up. And the first possible explanation with the sinus stuff is a virus. And so your brain is just going to start using a virus to explain everything about what's going on. As you witnessed my brain do and Dr. Singh's brain do. But you just have to kind of calibrate yourself to when to not trust that impulse. And there's just going to be so many diagnoses that like a URI, but the ones I'm thinking about are like pneumonia and UTI and cellulitis, right? That like your brain, and I'm just going to indict the urinalysis here because there's no worse offender in terms of search satisfying than the urinalysis. Like you're going to see like 9 blood cells in the urine and you're going to say, oh, they have a UTI, and you're going to turn your brain off. That's called search satisfying. Please try to avoid that because you actually saw all of the sort of I could see myself in a sizable percentage of scenarios hearing post-viral, like viral syndrome, cough, dyspnea, yada, yada, not feeling great. If like infiltrate on the x-ray or airspace opacity in the x-ray and and then, you know, writing for amoxicillin clavulanate and sending somebody home. So like, just so you know, this case unraveled with the data, and it unraveled with challenging the notion that this was just like post-viral crap. So so I just want to, that's like the big thing, is just like, is beware of search satisfying.
I guess I'm gonna add on related to a comment from Dr. Retrespo, is that like related to ultrasound, is that the absence of a finding does not rule out that possibility. The presence of a certain finding might help point to increase the probability of the diagnosis. So like the whole effusion and whatnot, where absence of the straining does not rule out the fact that it could be still exudative. The precedent might point to it, but it might, you know, you still have to tap it and see so in ultrasound, where the absence of finding, you still should not 100% rule that possibility. The precedent might help you lean one way versus the other. I think that is going to be the same thing for all ultrasound findings, at least for sure.
Thank you, Dr. Liu, and thank you, Dr. Restrepo, for co-discussing, Dr. Dansel, Dr. Sanjay Patel, and Dr. Travis Smith for also adding and lending their expertise with this case. So we'll go to Sarah for teaching points.
Yeah, thank you so much for this case. It was really incredible to listen to the discussion. So here are the teaching points that I would share. So we first started out with an approach to subacute dyspnea, which what we thought was a viral prodrome. So our initial buckets were post-viral cardiac disease like myocarditis, secondary infection like pneumonia, or alternatively that there was no original viral condition, which lends to more chronic sinopulmonary conditions like malignancy, especially in setting of constitutional syndromes, constitutional symptoms like weight loss that we had in this patient. There are some things that can narrow our differential, which we found in this case, such as this patient had shortness of breath without hypoxemia, which can indicate pleural effusion, anemia, or metabolic conditions like DKA. The patient also didn't have a fever, which could be indicative of a post-viral empyema, which can cause a subacute wasting syndrome instead of a pneumotic syndrome. The patient also had other interesting things going on, including new onset AFib, for which the differential was given to us by a mnemonic in the chat, PIRATES, which is PE, ischemia, respiratory disease, atrial enlargement, thyroid disorders, alcohol withdrawal, and sleep apnea and sepsis. The patient also had right upper quadrant abdominal pain, for which a common cause of abdominal pain in a respiratory syndrome is abdominal wall disease as opposed to abdominal cavity disease. So we can look for Carnett sign on physical exam. This is when the abdominal pain increases or is unchanged when tensing the abdominal wall muscles. And then finally, we took a look at a whole bunch of POCUS imaging. So the POCUS imaging for this case was important to look for things like consolidation, which also may look like pulmonary infarcts, pleural effusions for both size and complexity, volume status, and right upper quadrant pathologies. And then when we looked at the images, we learned several pearls, including for lung imaging, we can look for the spine sign, which is when typically you're not supposed to see the brightness of the spine in lung imaging because the air in the lungs can't transmit the signal from the ultrasound. But when the spine is present on imaging, you can see that's an indirect indicator that there's a pleural effusion in the lungs, but also sometimes can be mirror artifact. We also learned that loculated pleural effusions, which are indicated by this like spider webbing kind of feature, which is where there are loculations of fibrin around exudate. Finding this kind of finding most likely indicates either an empyema or malignancy. We learned this amazing pearl that infections will spread typically from the abdomen into the chest as opposed to vice versa, because the diaphragm tends to be a one-way valve because of the negative intrathoracic pressure. And then finally, we learned to be wary of search satisfying because in the end, it wasn't the viral syndrome that was the main driver of this condition, but in fact, it was the abdominal pain. And then we found that we can suspect pancreatic adenocarcinoma in someone who has recurrent pancreatitis with no specific cause found. And the diagnostic test of choice in this case would be an endoscopic ultrasound. And those are all my pearls. Thank you so much, everyone, for the discussion and teaching.
Great job, Sarah. You managed to catch all the highlighted pearls right there in your teaching points. So I really appreciate you taking the opportunity to present all of these teaching points. So I appreciate everybody coming on. And I think that concludes for POCUS VMR today. And I invite if Dr. Gigi Liu, Dr. Dancel, or Dr. Restrepo, or Dr. Sanjay Patel, if he wants to come back again, and you have any more cases, please reach out to us, and please feel free to present. But otherwise, thank you again, Dr. Patel, and have a great Tuesday afternoon, everybody. Take care. Bye.
Thanks.